depends upon, again, what type of foods you eat. But it could be anywhere from acidic, slightly acidic, all the way up to kind of basic. Yeah. Vegetarians are usually alkaline.
Basic.
Yeah. But average is about 6. So. And no, notice 95% water, 5% solutes. Okay. And the solutes are urea, salt, potassium chloride, creatine, uric acid. Okay. So when you guys, whenever I do a renal study, I always see if there's a urinalysis in there, or if they have any history of urinary problems like stones or things like that. This is another thing that you should be aware of here too. How much output is there? You know, so as part of your workup on the patient, you need to not only include some of the lab tests, but also, you know, this stuff here. Okay, normally about 1 to 2 liters a day. More than that, polyuria. Less than 500, oliguria. Remember, what does oliguria mean?
Sparse urine production.
Yeah. And then anuria?
No urine, absence of urine.
Okay. Now, most of the patients that we see for renograms are probably diabetic patients. You know, ones that don't have, they only have one leg, or they've had a couple of feet amputated, things like that. Diabetes is absolutely devastating. I don't know if you're aware that a lot of diabetic patients are the reason why we do gastric emptying studies. Gastroparesis. Yeah, gastroparesis. You get what they call diabetic neuropathy, where the diabetes actually destroys the nerves and they have no feeling. A lot of times patients that have diabetes don't get the urge to go to the bathroom. Okay? That's in the later things. Most of the times when you have diabetes, you're constantly going to the bathroom. So if you have people that you work with or children that are constantly going to the bathroom, that's why you need to monitor their intake and output. If they're drinking a lot, then you expect them to pee a lot. But if they have diabetes, then they'll be peeing a lot, even though they're not drinking a lot. So frequent urination.
And is that insipidus or mellitus?
Mellitus. Yeah, diabetes insipidus, you would not be leaving the bathroom. You would be drinking a gallon of water and peeing a gallon of water at the same time. Yeah. Yeah, just right through. Yeah, there's no ADH. Yeah, there's nothing there to tell the distal tubules to retain water. Those people don't usually last too long. You wind up with just totally out of the world electrolyte concentrations. Okay. So peeing a lot, and let's see what else we have here. Okay. Like I said, just be thankful you're not a lab person checking urine for diabetes. Okay, that's one of the things to be thankful for.
It's like, I'm like, don't we have machines for that?
Well, you have those little, no, that's why you have those little glucose strips to monitor the blood level.
Yeah.
Did they really used to do that though?
Yeah.
Isn't
But the teacher would go like this with his index finger and then like taste that with his middle finger.
Yeah, that's why you have
there
students.
you go now.
Okay, other lab students.
It's your turn.
Say yeah.
They still do that micro class? Is that what you're saying?
I hope not. I hope they don't do that. But if they did, I mean, you know, like I said, that was one of the things, was to check and see if it's sweetness. But as you know, diabetes also causes all sorts of renal vascular problems. So a lot of your diabetic patients, heart patients, you know, destroys the blood vessels in your eyes, so you're blind. Destroys your heart, your coronary arteries, your renal arteries. Yeah, so basically, but like I say, diabetes insipidus is a whole other animal. And if that happens, then, you know, like I said, most of the times people aren't going to survive anyway, but there's not really much you can do for diabetes insipidus, but that's drinking a lot and there's no ADH available. So that would be a question that I would probably ask you. What is the difference between diabetes mellitus, which is the sugar diabetes, and diabetes insipidus, which is the ADH hyposecretion problem? So one is you're going to be urinating a lot of water because there's no ability to retain it. The other one is you are excreting sugar because you have no ability to metabolize it. Okay. Now, diuretics. This is an important one for us. Okay, we do renal studies with diuretics. You guys have all probably done at least one. Ashley and Singh, have you guys done a Lasix renal study?
Yes.
Okay. On this one here, remember that we use the diuretic to rule out obstructed ureter versus a dilated ureter. You know, sometimes, remember we said that the calyces, the ureters, are muscular organs. They have peristaltic action. They literally squeeze the urine down into the bladder. If you have areas that are weak or not working properly, the stuff gets stuck there. So when we see something like that, we want to make sure that it's not a mechanical obstruction like a stone. If we give Lasix, then we should see that area clear out. Okay? If it stays there, then we now have an obstruction. So remember that furosemide and Lasix are one and the same, and so this is what it does. Okay? Increase urine output, decrease blood volume. One of the things you got to be careful of is, since these patients that are coming in already probably have high blood pressure, they may be taking Lasix as one of their control mechanisms for blood pressure. So by reducing the amount of fluid in the body, it decreases the workload of the heart. So make sure that if you're doing a renal study, that the patient hasn't taken Lasix. Okay. These are some of the things, these are some of the other tests that you might be seeing. They do have materials that they can inject. Well, I'm trying to remember which dye it was. It's not azure blue. Sometimes during cystoscopy, they'll inject azure blue or this blue dye, and then they'll wait till they see it in the ureter to get an idea of how good renal function is. That's what there's like renal clearance of blood plasma of waste in 1 minute. Let's see what else we have here. Does this look familiar? The 3 layers of your ureter. Where have you seen the adventitia? I would call this the tunica media, and this would be the tunica intima.
Blood vessels.
Blood vessels, yeah. Your ureter is very similar to a blood vessel. The transitional epithelial tissue, that's what gives it a smooth surface. The muscular layer here, this is what gives it peristalsis. And then the adventitia, that's the outer lining that provides blood or nourishment and oxygen to these other two down here. So it's just like a blood vessel. You have an outer layer, which is the adventitia. You have a middle layer, which is the muscularis. And then you have a mucosal layer, which is epithelial tissue, which gives it a smooth lining. Okay. And this is why when people get stones in there, they're so painful, because basically it's a muscle and it's spasming. It's trying to force that object out. Anytime you have a muscular, like blood vessel or ureter, anytime it feels distension, that stimulates it to contract. It's like peristalsis in your stomach too. Whenever there's a blob of food in there, that stretching of the muscles in the intestine tell it that it needs to move stuff along. Here's the bladder. Okay, I put this in here because we do cystograms, right? And we normally put a catheter in here, and as we're filling the bladder, we need to monitor how much fluid we put in so we can document the time at which reflux occurs. Remember, this is the vesico-ureteral junction here. There's a little valve that's supposed to prevent the backflow of urine, but unfortunately some kids, they don't have that ability. So here's the opening of it too, by the way. So the ureter comes down, it goes behind the bladder and comes in at the base of the trigon. When the person urinates, the bladder constricts. This detrusor muscle is the one that controls that. But sometimes when they urinate, urine is forced back up the ureter. Okay. So that, I would say that's the majority of cystogram studies that we do are for reflux. Okay. Remember that the trigon is that area down here. It sort of guides the urine out the urethra. Let's see what else we have here. This is an important one. The adult capacity is about 500 to 800 ml. So if you're doing a adult cystogram, don't put the whole 1,000 ml in there, please. I mean, I've seen it where people have had bladders that literally go up almost to the bottom of their chest.